This conference will now be recorded.
Hello, it's John Antonucci and Rick Davis. We are covering for Mark Perlow tonight in AnCan's low
And Jim Schrate.
And don't forget Jim Schrate, covering for Mark in AnCan's low and intermediate risk prostate cancer support and discussion group. We will share our experience together, try to resolve any questions that are coming up in your treatment plan. We can't give medical advice, but we have a lot of experience between us, and I'm sure we can provide some help with some people. We are partially sponsored in this group by Bayer, Johnson & Johnson, Myriad Genetics, Telix Blue Earth, Foundation Medicine, and Novartis, who support us without requiring us to endorse any of their products. We have a couple of new guys, so I'm going to start with the new guys, get some background information. I'll pass it on to Dr. Mark, or Rick will. And Rick, do you want to take notes on them, or do you want me to?
You're moderating, so I'll take the notes for Dr. Mark. I will say that the reason Dr. Mark is not here is because myself, Dr. John, and Dr. Mark are all going up to San Francisco for the Genitourinary ASCO 2025 conference, which is Thursday, Friday, and Saturday, although the prostate cancer part is really only Thursday. There are something like 40 abstracts and papers on low intermediate prostate cancer, although I, to be honest, have not looked at them. Maybe Dr. Mark will, maybe Dr. John will cast his eyes over them. I spent a couple of hours today going through and picking out about 40 abstracts of interest. I'll be lucky if I get around to 10 or 12 of those posters. I sent Dr. John a list of those posters as well in case he hadn't had a chance to go through. These conferences are they are a whirlwind. Dr. John and all three of us will try to spend most of the day in the plenary on the first day, which is where, if there is any good information, you should hear it. And that can be everything from active surveillance all the way through to end of life. It's not restricted just to advanced. There are presenters on all of that. If anybody's it might be too late now, but you can get, as a patient advocate, you can get a virtual pass for free, but they have to verify that you are associated with an organization. If you're very interested, send me an email and I will send you the information. We certainly put it in the advanced group. I'm not sure we put it in the other groups. We'll be meeting with sponsors. I think I have 8 meetings scheduled on Friday with existing sponsors and potential sponsors. And then we have to walk around the exhibits and try and schmooze people, learn things, pick up any interesting freebies. It's an experience, as I say. So, and the reason Dr. Mark isn't there is because he has taken his good wife Mary up to Carmel, which they have to pass through on the way to San Francisco. So they drove up, and he is staying for a couple of nights in Carmel. So he asked if we would cover for him tonight. So with that, I'll let you go, Dr. John.
Let's start out with Greg. There was a little uncertainty about which group to go to, but I think we got it straightened out now. So, Greg, I'll ask you a few questions like we started to do in the other group, okay?
Sure. Thank you.
How old are you, Greg? You look kind of young.
I'm 57.
Okay. And where do you live?
I'm in Yorba Linda, California,
Where's that in California?
near Disneyland.
Oh, near Anaheim. Okay. And tell us a little bit about when you first got diagnosed. How did that come about, and when was it?
So I don't believe I have cancer, so I still don't know if I'm in the right place. But okay, I've been having prostate issues since I was about 50. I just started with a really weak stream. Do you want me to go into more detail, or do you want to ask the questions and I'll just answer your question?
Let's save the details for when we get into the questioning
Okay.
because it's not even. I remember now. It's not even a certain thing that you have cancer at this point. We're just learning how to be vigilant here.
Hmm.
So you've had prostate problems for a number of years now, but uh, now, if I remember, you have not even had a biopsy, right?
No, I've not had a biopsy. No.
Okay. So tell us the reason for concern and what you came to the group for.
Well, as I mentioned, I first visited my urologist 7 years ago. I see him every year, and he's having really weak stream problems. He put me on some medication, which was Flomax. A couple years later, it wasn't working as well. He doubled. He said, "Okay, take twice as much." Okay, that worked well, and it wasn't as effective. And then he put me on Finasteride as well. So I'm on 3 different pills daily. And it's just even each year as time goes, it's more difficult for me to go to the restroom, and I'm starting to get a sense of urgency at times where it sneaks up on me, and I'm like, oh my god, I'm gonna explode. Um, and so I'm considering surgery, and I wanted to just get some experience from other men who might know. Is there a reason I should avoid surgery, or if not, what type of surgery should I do? I'm just looking for feedback other than from a doctor, from men who've had this experience. So I'm looking
So it
for.
sounds like you have two kinds of urinary symptoms. One is that when you try to pee, you're 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 pushing through a partial obstruction, so it's difficult to get a good strong stream going, and you probably have a fair amount of urine left in your bladder after you go. The other is that it gets to the point sometimes where you have a feeling of urgency, where you better get the heck to a bathroom as fast as possible, or you're afraid you're going to leak,
That's correct.
right?
That's
Okay.
correct.
Um, and as far as a diagnostic workup, so far um, you've probably had urinalysis, you've been on medications, you've probably had some blood tests. Have you had an ultrasound of your bladder?
Yeah, I've had ultrasound. I've had 2 times where they take a camera and they go up your urethra to look inside your bladder, and they've done that twice. And the doctor wants to do that again in March before.
Cystoscopies, okay.
Yeah.
And
So
what did they say was the cause of the obstruction
he
on your
just said
cystoscopy?
an enlarged prostate is what he just said. So it's just that's it.
Okay, so you've gotten as far as you can with medications, and so now you're considering a uh, surgical solution. And what is your current PSA level?
I think it was 1.5 recently.
1.5 for a
It's
50.
been a very stable PSA measurement. Well, on terminology I'm not familiar with, but I've been consistent with that that number. He did an ultrasound on my and he said it was enlarged, very large, and I don't know what that means. And you may ask me what was the measurements. I don't have that, but he just said there is no normal. Everyone's different, and most important for me was that the number doesn't change. which it hasn't necessarily changed. It's been stable. However,
Okay.
yeah.
So you are working with a presumptive diagnosis of benign prostatic hyperplasia. When you have pretend the prostate is a ball and there's a tube going through it. If the ball becomes enlarged, it enlarges both outward and inward, putting pressure on your urethra and causing the symptoms that you're having. The fact that you have an otherwise normal cystoscopy, normal urinalysis, and normal PSA, which hasn't changed, suggests that prostate cancer is very unlikely to have anything to do with your symptoms. So you're going to be probably recommended to have some type of procedure like a TURP. I'd like to know if anybody here, and I bet there is somebody,
Yeah.
who on their way along the way has had a TURP and whether it was painful, painless, helpful, not helpful. And then I think we can have Greg ready for whatever's going to come next. Any takers? Now that's a surprise to me. You usually get
So,
you get a room full of gentlemen of our age, and to have nobody having had a TURP is
well, I
surprising.
think one reason, Dr. John, is because most of the guys who are facing these issues, you'll find in the active surveillance group.
Yeah.
Right, right, right.
And my suggestion to Greg, I think we suggested this also last time, is to join the active surveillance group on a Wednesday night. They meet the first 4 Wednesday nights of the month, first, second, third, and fourth Wednesday night, same time, exactly the same place in here. You may even see Counselor Jim Schrate in that group as well. And they do tend to talk a lot more about BPH
Okay,
and address BPH. Now, we actually did a webinar on BPH 2 or 3 years ago with one of the best benign prostate docs in the country, and who's at Mount Sinai. I'm going to put that link in the chat window for you momentarily. I think it's called It Ain't Your Grandfather's BPH, and it was a pretty good webinar. And I can tell you that they know quite a bit more than we do. And I think one of the reasons that you don't have a lot of guys here is because they're sort of beyond the BPH stage.
yeah,
Um,
yeah. And in high risk, we wouldn't have them because nobody there has a prostate anymore, hardly. But what it's like is it's very much like your cystoscopy, except it takes longer, and you might have a fair amount of bleeding afterwards, but the tunnel through your prostate will be wider than it is now after the procedure. I don't I don't really see that you are going to really have much choice because you've been through medical treatments already and you may have to resort to a surgical intervention. So if you can find somebody in the active surveillance group that actually had the procedure, you can get some firsthand knowledge of what it's like. Um, but I think you are probably fated to have it at some time in the future. Let me go to Jim Marshall, who is here.
Uh, yeah, I was going to point out for the TURP. Okay, the TURP is essentially a laser, and there is a procedure out now that uses essentially a water jet. Now, I don't know uh, which is the best to do or the least side effects, but there is an alternative.
so
And
there are several
right,
alternatives, Jim. There's
is there?
steam, which is the resume. There's a water
Okay,
jet. There's a green laser. There's a TURP, which is again something different. but we really, again, it's not really something we get into in this group. And
Right.
I don't want to get into the weeds of this, but when you have an enlarged prostate, like we say, the best place to be is the active surveillance group because they really can and do address it.
One thing
Okay.
we do want to make sure of, though, before we let you go, is to make sure that you have an expert urologist and you're happy with that person. Tell us about your urologist and how much confidence you have in him or her.
I like him. He's a younger guy. He seems pretty straightforward. He's good. I have trust in him. I just want a second opinion. I want to make sure I'm doing the right things. He originally wanted to do surgery off the bat, and I want to push that off as long as I can. So I have faith in him. But
Good.
it's always good to get a second opinion because, again, that's why I'm here, just to get opinions from other men. So I will go to that active surveillance group. I thought this was the right one. I know you told me Wednesday, but somehow I messed that up. So
Check out the chat, which is the two little boxes in the upper right. Rick has posted how to get to the BPH webinar. Jim, would you finish up what you had to say?
Yeah, just to point out, because you were on, or I don't know if you're still on the Homax, that is known to drop your PSA score by half. So be aware that it will then artificially decrease it in half. So provided it looks good, essentially at a 1.5, it's actually 3. But the thing I believe that you are looking for is a incremental increase over time. And that's why a PSA test every 6 months or every 3 months might be a thing to pursue.
Okay, thank you.
Okay, Greg, I co-moderate the active surveillance group, and we do talk about BPH from time to time, and I think we can probably find you a couple guys that maybe have had one or the other of the treatments. So do join us on Wednesday night. We'd welcome you. I was curious as to what specific procedure your urologist is recommending and whether he's told you why he likes a specific procedure, anything like that.
I do remember him saying TURP was what he recommends. I asked him because my general doctor, he had said, "Oh, why don't you ask him about the green laser?" So I asked him about the green laser, and he said he didn't answer my question. He said, "Do you have faith?" So he kind of dodged my question and just said, "You know what? Before we do anything, I want to get in there again with a scope and look and see what's going on, and then we can talk about it after that."
Okay.
So for my knowledge, it's the TURP is what he does. But like I said, he's a younger guy. I think he looks like he's late 40s, early 50s, and he seems like he's new technology. Has got a nice office. Everything's clean. It just looks like he knows what he's doing. But I haven't seen another urologist. So
all right, well, join us on Wednesday, and we'll try to hook you up with some people who have some direct experience with this.
Okay, would that be? And it's on the website. Would that be this Wednesday? Because somebody said the first Wednesday of each month.
No, it's every Wednesday except if there's a fifth Wednesday we don't meet, and it's same time, same place.
Okay.
So you get to us exactly the same way you got to this meeting this evening.
Okay, I'll be there.
Okay.
I'm gonna get to a couple guys with their hands raised and then go on to the next new guy. Sandy, I got you have a hand up.
Yeah, kind of a related question and or comment. The radiation oncologist I'm working with, considering the seed brachy solution for my cancer, indicated that he can't do anything unless I have a TURP procedure from the urologist or greenlight laser. Now, can anyone speculate why that is? Is it because the radiation seeds will cause so much swelling that it'll completely cut off my urethra, or why would he suggest that?
I would say yes, that's probably the reason.
Okay, so I'm going to proceed with another urologist second opinion, and Dr. Ming Zhao is reading my biopsy again, but I was just curious, there'd be so much swelling that I couldn't pee at all. That's why they suggest I have to have that done before the radiation seeds. Is
Now,
my
that's not standard for everybody, so he must have felt that you have a narrow
yeah.
urethra.
MRI
And
this week, so we'll know, I guess, more then. Okay, thanks, guys. I'll sign off.
Yeah. How large is your prostate, Sandy?
Don't know. Haven't had the MRI or the PSMA PET scan. That happens Wednesday of this week.
So
But
let's
while I have,
come back to you. Put Sandy down, and we'll come back to that.
yeah, I got
Okay.
another one for you, Rick. We'll talk about. Okay.
John, got your hand up.
Yeah, just a little correction. It's the finasteride that drops your PSA in half.
Yes, you're
And
right. Thank you.
yeah, just a little correction. It's not the Flomax. And the other thing is I've been on Dutasteride, which works on both receptors. It's a much more powerful BPH drug, and the half life, I believe, is 40 days versus 12 to 18 hours for finasteride. I don't know if that's going to make a difference in shrinking the prostate, but just something to keep in mind.
Put it in the chat so Greg can ask his urologist about it, please, John.
Thank you, John.
All right, I'm on a webcam now. I switched. I'll figure it out. Okay.
Okay,
All right.
just let us know if you can't figure it out.
Yeah, I'll figure it out.
Thank you for the correction.
I
Bill,
am.
welcome to group.
Thank you, John. Dr. John, I appreciate it. I can just go ahead and give you the name, rank, serial number piece and all the information if that works for you.
Well, that reminds me of another question we often have, which is, are you a veteran?
No, I'm not a veteran.
Okay. How old are you?
67.
Where do you live?
I live outside of Portland, Maine.
Oh, you're in the Northeast, like I usually am.
Yep.
I live in Connecticut. So tell us how you got started on this. You came from active surveillance, so you probably got diagnosed some time ago.
Yes. I was diagnosed in December of 2020 and have been in active surveillance since then. In terms of the diagnostics, 4 biopsies in 2020, 21, 23, and then the most recent one in December of 24, and then 3 MRIs in 21, 22, and May of 24.
Now, you really put the active in active surveillance, 4 biopsies in a few years.
Yeah.
I can't wait for the rest of it because now we'll find out why so much. Go ahead.
Yeah, it's a little bit of a tricky situation, which has just recently become more tricky. So the PSA has risen from 2.4 to 9.2.
All right.
Since December of 2019. PSA density is at 0.41. So that's my 9.2 PSA into a 22 cc prostate.
Yep, high PSA density.
Yep, Gleason 3 plus 3 equals 6. But sort of the skunk at the garden party was the DECIPHER came in at 0.91.
Okay.
In the context of a 3 plus 3 equals 6. And then father had prostate cancer, diagnosed at age 75, Gleason 9. Thankfully, he got the brachytherapy and ADT treatment, and still kicking and moving along and annoying a lot of people at the age of 96. So a happy ending for him. So I do have some mild urinary problems and some not so mild sexual function ED problems, which sort of add into the drama, if you will.
That's I can't access my camera.
And you've had no treatment so far, right?
No treatment so far. Trying to figure out the best way forward because we've probably gotten, with the DECIPHER and the increasing PSA, have gotten to the point where it's maybe time to really seriously consider doing something.
Yeah. Now so I can see where the confusion lies. You're 3+3 and your long indolent history puts you in active surveillance. Your DECIPHER score puts you in high risk. So here you are in the middle wondering what to do. The DECIPHER scores, we've noticed that recently they're starting to come out with what's called a grid report. Did your DECIPHER score happen to have a grid report attached to it? GRID.
It did not. I actually reached out to the VeriCite people and asked them what I needed to do to get the grid report, particularly given, sort of the family history. They said that I needed to go ahead and contact my urologist.
Yeah, your doctor has to fight for it.
Yep. And they said that it would be, they'd be happy to send it and it would be free of charge.
Yep.
So I'm on my third or fourth email with my urologist and his group to try and get them to reach out to VeriCite and get the report, which I have been unsuccessful to this point, but I will not continue to be unsuccessful.
Let me explain a little bit why they're being so tight-fisted, and I can see that you've already looked into this quite a lot, but for everybody else's sake, the grid report is a more expansive genomic analysis of Bill's biopsy samples. However, it is at this point entirely experimental for research purposes only and not FDA approved for clinical use at all. However, there's a lot of stuff in there, but you can accomplish something else genetically besides the grid report. You can get a germline color test or another germline test because wasn't it your dad you said had prostate cancer?
That's correct. Yeah.
That might be another little bit of information. You may have inherited an abnormal gene from your dad. That gene may be what triggered off your DECIPHER report. We don't really know. But even though it's not a requirement, if I were you, I think I'd be pretty curious about what I inherited from my father, and I might either ask the urologist for a germline test or go ahead and get a free one from Color, which is a company that's collecting a large database. And Rick will probably show you a portal through which you can request it. They'll send you a swab, and you can send it back and get a nice report, and they'll also let you talk to a genetic counselor for free.
Let's ask him first if he's done it, John.
Okay.
Have you done it?
I actually started to do it and then saw, Rick, that I would need to go ahead and reach out to my urologist. They would need to reach out to my urologist to get my information.
No, you can do it all on your own.
You can do the promise test. I'll put the link in, but you can do the promise test. Just tell them not to send it to you want to tell them not to send it to your doctor, that you want them to contact you directly, but you can get that directly. Now, the only thing I will say is this: that test is a small panel. It's about 32 genes. They don't cover all the genes. If there are some more unusual genes that might be playing a part in this, and it sounds like there might be, then you are better getting a germline test through your doctor, because they order it from people that have more expansive panels.
Okay, it would be germline.
So
Yep.
what you need is a germline test to see what you've inherited. It doesn't hurt to get the color, but I might also want to get a more expansive test from one of the other providers.
And the grid is probably the most expansive if we can go ahead and.
Well, the grid's going to give you a bunch of information. You know, I still stand by the information I gave you a couple of weeks ago,
Yep.
which is to get hold of one of those docs at Dana-Farber and let them dig into it, because your situation is unusual. There's something going on that isn't regular. And I think I sent you a couple of different names.
You did.
Doctors, I can't remember their names off the top, but if you can get in with one of them and have them pursue it, and that's where I would go.
And I have pursued that. Rick, thank you very
Yep.
much. I actually got a connection through Access Hope to Dana-Farber and got a second opinion there from one of the oncologists. But I will follow up. I have a referral in from my primary care physician for one of those doctors that you recommended at Dana-Farber. So we just got to keep pushing and moving forward and you know, to get the information we need. But
We
thank
want
you.
to emerge from this with an explanation of why your PSA is what it is. Has anyone actually ordered a PET scan, or but you have had an MRI?
I had one in May of last year, yeah, which
Tell us what the MRI showed.
it didn't show anything outside the prostate being an
What
issue.
did it show inside the prostate?
It showed cancerous material in the right base and in the left mid, both less than 5%. But in the anterior mid, it showed 3 cores out of 3 that had 40%, 10%, and 10%.
So you're in your biopsy report now, it sounds
Yeah.
like.
Yeah.
And did your biopsy report use any words like cribiform or intraductal? Do you see any words like that?
No.
No. Okay. That's all my questions. Who else has any feedback, information, encouragement, shared experiences?
It's kind of an unfortunate situation to be unique. So we just got to get to the right people. But this is enormously helpful.
Okay.
Thank you.
Okay, very good. If you actually do end up getting your hands on the grid report, and you want to discuss how to interpret the report itself, you're welcome to write to me. Otherwise, your urologist will take care of it. Rick will put my email address in the chat.
Perfect. Thank you, guys. Really
I
appreciate
just have one question for you, Bill. You said your PSA had gone from 2.4 to what was your most recent?
9.2.
Yeah, that's what I had. I just wanted to confirm that. Okay. I mean, you know, it's the 9.2 is concerning in a 22 cc prostate because it is significant. Yeah, I think you've got to get a really decent. You said you got a second opinion from an oncologist at Dana-Farber. What type of oncologist was that?
Hang on a second. He is his doctor. His name is Dr. Wenzin Zhu, Wenxin Zhu, and he is a
Was he a surgeon, a radiation oncologist, or
no, he's an oncologist.
A medical oncologist.
He's a medical oncologist. Yeah.
Okay.
All
right.
Yes,
Well,
he's a janitor. He's a GU oncologist and clinical researcher with a focus on kidney biomarkers.
I don't know him, but that doesn't mean a lot. We do know a bunch of the GU medoncs there, but he's not who you should be seeing in my view. I would be seeing a good urologic oncologist, a surgeon who is not too quick to cut, and those are the names that we gave you. So come back. Anybody else have any thoughts on this? High PSA, high DECIPHER 3+3. Anybody like Eric, for example? Because I like to pick on him.
Yeah, I mean, I'm not high PSA, but I do have high volume.
Yeah. Yes, sir.
So I've been getting my next MRI is at the end of the month, so getting that done. But have you done any lifestyle changes, exercise, nutrition, any of that kind of stuff?
Me?
Yes, you, Bill.
Oh, yeah. I work out every day. I eat carefully, get enough sleep.
Perfect.
Yeah.
That's a good start.
I'm otherwise very, very healthy.
And do you think your PSA was skewed by the time of day or anything that you did the day before? Or?
I mean, the most recent PSA may be skewed, but the trend line is not, and the trend is not my friend, unfortunately.
So if you exclude the last one, what was the one before that?
The one before that was, give me a second here.
Or what was the last three trends, I guess?
Yeah, it's gone from 3 of 24, from 7 to 9 of 24, 8 to 11 of 24, 9.2. So, bad trend.
Yeah. It could be BPH. You're having urination issues.
Yeah.
So
there's, the biopsies. I mean, there's definitely cancer in there. It's not a high volume, not like you. So I guess you and I are twins of a sort.
Yeah, of a skewed nature.
The skewed nature. We're bookends.
Yeah. Well, the highest DECIPHER is a cautionary thing for sure.
Yeah. You remember a biopsy takes, I don't know, a couple of % of your prostate to sample. It misses things sometimes.
So let's just move along. I'm sort of watching the time because I know a bunch of people have got, and we've got to go to David as another new guy, but there are a couple of hands up. So
David, which David is a new guy then? David. Oh, okay. Okay. I forgot you were new. Okay.
Sort of new. So Michael Williams, what's on your mind for this?
Oh, I was just going to comment that, and I'm kind of in the same situation with this gradually rising PSA, that I would strongly want to get the genetic testing. I would push for that right away. And Rick's right. I I actually did have the testing done at Mayo, and then what had happened was I had sent off for the promise at the same time. I didn't realize Mayo was going to order it, and it was nice to see them both compare and be the same. And then also based upon my family history, then Mayo wanted to order an even more extensive test because my brother had had kidney cancer. When I finally did a genetics counseling session on via Zoom. But I would really want the results of that. You know, I would see that as very important in your case.
And
Thanks, Mike.
David with the white shirt. I assumed that we already knew you from active surveillance. Should we go ahead and get a whole background, or
John,
Jim?
hold on a minute.
No.
You still have somebody with a hand up.
Oh, I do.
Jim
Who's that?
Marshall. Jim Marshall, you had your hand up.
Question, Bill, do you possibly pump iron?
No.
Oh, okay. I was curious. Okay.
If you saw me, you'd know that I don't. So. Thanks, Jim.
So, Rick, or Jim Schrate, or give me some guidance here whether we want to start all the way from scratch with David, or whether this is just a transfer from another one of our groups.
Well, it is a transfer, but I don't think this group has any knowledge of David. So I would rush through him, run through him relatively quickly, and so we can get to our questions.
Okay, David, hit it. Age, location, and a quick summary of your diagnosis and treatment and present questions.
Okay, I'll be as brief as I can. I live in Scottsdale, Arizona, 78 years old. I had bladder cancer in 2000. I licked that, BCG. I was diagnosed with prostate cancer about 10 years ago. I've been in active surveillance since then. My PSA has been 3.3. Gleason's been 3.3. PSA's 2.5 for those 10 years. About 6 months ago, I'm dealing with, 6 months ago I had another biopsy and it went up 3.4, and PSA went up to about 3.5, 4. So that's the first change it had been in probably 10 years. I had the Polaris and the Decipher. The Decipher was 6.5. The latest one I had, that was about 6 months ago. I'm dealing with a number of doctors. I have my regular urologist, but he suggested I go. I'm here in Scottsdale, so I went over to Mayo. Also went to SPRT. Is that a typical thing, or that's the high fractionated radiation? Just
SBRT tends to be few fractions high doses, like 5 sessions.
Yeah, 5 of them versus the standard radiation of 45.
Yeah.
So I looked at both of those things. I'm looking at, there's a local guy that does the SBRT, so I'm looking at him. But I'm going back to Mayo because Mayo, I had a biopsy 6 months ago, and because my Decipher score was high, Mayo suggested they do another one. They did another one last month, and I went from 3.4 to 4.4, and my PSA went to about 4.5, and I've got some cribiform. Does anybody know what that is?
Yes, yes, we do.
Yeah.
And we've lately been paying attention to so-called large and small cribiform.
Yeah.
Did you get any kind of an adjective with your cribiform?
You know, Rick, no, I don't know. It was just in one lesion.
Okay. Okay. So that was a very good rapid fire summary. So
yeah. Well,
something is clearly on the move.
Yeah, let me say one other thing. I'm 78, but I have a young girlfriend, a young fiance. So life, what I call life and lifestyle. Life is important to me. I'd like to lick the cancer, but I have a young girlfriend and fiance. So life. So the side effects are important. So the last 6 months, I've been I was hoping to do TULSA. I talked to UCLA about TULSA. That was my prescribed way of going at it. UCLA does NanoKnife, so TULSA and NanoKnife were my choices at the time, but now apparently it's gone from 4-4, and with the cribiform, those options are out. So now I have to do radiation of some sort. They are doing a PET scan. They're concerned about it. They're doing a PET scan this Friday, Valentine's Day, and so I'll know more at that point. So they're holding on the radiation. They're holding on the. I've talked to the surgery guys, you know, the prostatectomy, and obviously that's a direction I don't want to go in.
Yeah.
So right now I'm
And
thinking,
your PET scan, is that going to be a PSMA type PET
yes,
scan?
yes,
Okay.
yeah,
Well, presumably your cancer is expressing PSMA, and you'll get a strong hint about whether it's entirely confined to the prostate gland or not
right,
on Friday, and that will help guide your next decisions.
exactly.
Well, I think there's a few things I would do. Who are you seeing first of all? Which urologist are you seeing at Mayo? Which urological oncologist are you seeing at Mayo?
YU.
Okay.
My urologist there is Frendel. Frendel does the NanoKnife, and he's got some other test things going. He's got some water
Yeah.
tests,
So
steam tests, that sort of
so
thing.
when was the last time he did a biopsy? If you went to 4+4, it must have been quite recently.
Yeah, a month ago.
And was that a transperineal?
Yes.
Yeah, because he does that. Okay.
Yeah.
Now, the first thing, if it were me, that I would do is I'd get those slides reread. Where were the slides read? Just at Mayo?
They were. Yes, they were.
Okay.
I think you mentioned some time ago something about not St. John's. What's it?
Johns Hopkins. But
Johns Hopkins. Yeah.
yeah.
Was that you?
What you want to do immediately, so, call Frendel's office tomorrow and have them send those slides to you can choose either Dr. Zhu at Mount Sinai or Dr. Epstein, who is now in a consulting situation. We can put his information in the chat window momentarily.
Yeah.
But one of those two men needs to take a look at the slides, see if they agree with the 4+4, and see if they agree with the crib reform.
Okay.
If they see crib reform, it immediately makes it a 4.
Yeah.
But the question is, how much 4? And when you go from 3+4 to 4+4, you've gone up 2 categories right there.
Yeah.
So that's the first thing. So we will put that information. Keep an eye on the chat window. We'll put in information. Somebody else has got those email addresses. Please put them in. In my view, and I'm not a doc, but if it were me, I would never be looking at surgery anyway at age 78.
No.
It's not a viable option.
Right.
What is a viable option is some type of radiation, and they may want to add to that depending on how extreme. So you could be doing SBRT plus something to the gland, IMRT across the pelvic girdle. You could be doing brachytherapy, high dose or low dose. How many cores positive do you have?
There were, I believe, 4 at 3, 1 or 2 at 4.
4. So with 4, they could do low dose. They might do high dose. They do high dose at Mayo. I know that, high dose brachy. But what? The best doctors right now are leaning more towards SBRT. They think it's just as good as for the treatment to the gland, or as the what they call the boost, and then doing the IMRT across the pelvic girdle, which you could certainly do at Mayo. But I think the very first step is to confirm your your slides. Jim,
Okay.
Jim Schrate, what would you say?
I agree with you completely. I mean, it looks like you're headed for some kind of treatment, and it's critically important that you have a good foundational diagnosis.
I guess my issue is that, are they going to be concerned about that? If I ask them that, are they going to be upset that I'm getting another opinion?
They shouldn't
No,
be. They shouldn't be. No.
no. It's pretty routine to get slides reread.
Okay.
And so, and I actually know Frendel, and I can't imagine he's going to be offended if you tell him you want Epstein to read your slides or Dr. Zhu to read your slides. Um, I doubt it very, very much.
Okay.
And even if he is, he ain't the right doctor, because of what's more important, that you get an accurate and true reading of those slides, which are very, very important right now for you to base on,
Yeah.
or a doctor who's offended. But I don't think it's very rare that urologists are offended by getting a second opinion on
Yeah.
a second
Okay.
pathological opinion.
Well, would you call it asking for me? I'm kidding. I'm kidding. Because I'm chicken.
I know. I'm smiling. It's a good line. I should have thought of it. What I want to get Epstein's new email address. Here it is. So you can send an email to this address tomorrow, or you can ask them to contact this person to find out how best to send slides to Dr. Epstein. He's back in. What we've heard is he's back in business as of this week, as of this month.
Okay.
So let me put that in for you right now.
Looked like some sort of private group, didn't it, Rick?
Yes, I'm almost certain it is.
Yeah.
But he'll still talk to you. He's doing all the same stuff he was doing at Hopkins, and it doesn't really matter where he's working. It's his eye that you want to use, rather than his whoever it is that's employing him, or
Yeah.
he may be employing himself.
You think Zoo is either one, Zoo or you've mentioned Zoo to me before.
Yeah, Zhu is good, and I don't know. If it were me, I'd probably go to Epstein.
Okay.
He's the guy who trained Zhu.
Oh, okay.
So I would probably go to him.
Yeah.
Um,
Did you ever hear of Dr. Kressel with SBRT?
Where is he?
John Kressel, Scottsdale here.
I wouldn't use. I was just talking to somebody else in Phoenix today about community doctors.
Yeah.
I would not use a community doctor when I can go to an NCCN center.
Yeah.
Yep.
Or an NCI center.
Yeah.
So for me, they're not the best choice. I mean, I would, if I needed radiation in Phoenix, I'd be going to Mayo, or else possibly to one of the affiliated NCCN hospitals like City of Hope or MD Anderson. But even then, I'm skeptical. City of Hope happens to have a really good guy in charge of the GU program, Alan Bryce.
Right.
But
Yes.
but if you're already at Mayo, I would stick with Mayo. I mean, why would you want to go to a community doc?
Yeah. Well, they are in business. That's the problem I've had with my urologist is with a community group, and he has one option, and obviously, I think they're all as objective as they can be, but they're in business.
Yeah, but you see, that's why you go to That's why you go to a center of excellence, because they don't get paid. They're salaried.
Right.
And so it doesn't matter to them if they treat you or they don't. They're still going to get paid the same.
Right.
Whereas your guy who wants to do SBRT on you, he's going to give you every reason why you shouldn't do brachy because he doesn't do brachy.
Yeah. Exactly.
I am going to move on to the regulars. David, if you turn out to have any metastatic disease on that PET scan, we would extend a welcome to visit us in high-risk group.
Well, it turns out, no, I do not have metastatic.
No, hold on. We're talking to the other David.
Sorry.
And just one, David, what's your last initial, David?
P.
P.
Oh,
That's yeah.
oh,
And you are in our database, right? You're getting reminders from us.
yes.
Okay, fine. So
But I have called you. I have sent you emails, and I'm not sure you're getting them. So I'm not sure what's going on with that. But
well, I don't know, but you shouldn't be sending me emails if this is you should be sending them unless you're 4+4. You should be sending them to Mark Perlow, Dr. Perlow, or one of the other guys because
yeah.
I just can't handle everybody. Sorry.
Sure.
Tell us how many, Rick, tell us how many emails are in your inbox right now.
Oh my God. I can tell you how many I get a day, which is about 40 to 50.
How do you like that?
And so it's a question of unloading them to people, kind people like Dr. John.
People like me.
So
yeah, we're fine. I'm fine. Thank you. I'll get that.
Okay, David S., please complete that sentence you just started. Unmute.
Okay, so yes, since just to kind of catch you up on what's been happening, a lot's been happening, and to remind you, I've been diagnosed with 4+3+ cribiform, and I got my PSMA PET scan result last week, and also did it last week. Got the scan last week and got the results last week. It showed no metastatic anything. It's all still in the gland. And I did get, I sent away for 2 PROSTOX tests, and one of them came back, the SBRT. I am low risk for that. And I contacted my urologist today just to confirm that they had sent off my biopsy slides to Mingzhu and Johns Hopkins as I had asked them to about 2.5 weeks ago, and it turns out one of them fell right through the cracks, and the other one only got sent out about 4 days ago. So I don't know how long it takes at that point to get a response. Does anyone know how long, once Johns Hopkins gets the material, they turn it around and get back?
So Mingzhu is pretty good, and we'll get to it. Johns Hopkins is a big old black hole.
Okay.
And you got to stay on them. And we are aware of slides getting stuck on a shelf for weeks at Johns Hopkins.
Oh, really? Ooh,
yes. Okay. Now, it's not always like that. And certainly when Dr. Epstein was there, they weren't bad, but they don't have a great rep. So stick on them. Okay, make sure they got there and make sure they didn't get lost along the way and all of that good stuff.
Okay.
Well, David, can I ask David a question?
Sure.
Can you have your doctor send that, or or Rick, your doctor can send that to Johns Hopkins?
Yes, all of these slides should be sent through your doctor, not by you. You just ask your urologist to send them to either Hopkins or Zhu or Dr. Epstein, wherever you want.
Gotcha, thanks.
My bet, if he's up in biz already, my bet is the quickest would be to go to Epstein because he's not part of a system. But that's just a gut feel.
I've already sent him out to 2 different places.
Yeah.
So.
And here's the other thing, and it's unusual to get. Usually, you can't get them sent out to do different places at the same time. You have to send them to one, and then they have to come back, and then you have to send them again.
Oh, really? Oh, yes. I didn't know that. Okay. I don't know the mechanics of how that's done, so I'll check into that. But anyway, so that's what's happened in terms of test results. And I've also got 3 appointments lined up with radiation oncologists, 2 of them here in Portland and 1 of them in at UCLA, Dr. Chang. Because of the cribiform, because of the 4+3, and because of a study I just came across, it came out a couple of years ago. It was quite an interesting study. They had taken 53 prostates that had been surgically removed from guys who had already had radiation treatment for prostate cancer, and did a pathology test on what's going on in these prostates that made them have a recurrence. And what they found was about 80% of them had cribiform in them. So it seems like it might be a very stubborn thing to kill.
Yeah.
My feeling is you probably, I'm leaning toward brachytherapy, specifically HDR, because it just seems like that would just have more dosage to it in terms of killing cancer than beam radiation would. What do you think of that?
It
So
might
did
not
you
be
say
sufficient all by itself.
And why is that?
What do you think, Rick? Brachytherapy, monotherapy.
let me just step back one. Did you say you were going to see Albert Chang?
I'm going to see him on video on over the internet.
Oh, well, you tell him Rick Davis from AnCan said hello. How
Okay,
are you?
I will.
Okay.
Okay.
And if you talk about the Dodgers, he'll love you forever. All right.
Hey, all right.
Don't talk about the Giants. He begs him, even when he was in San Francisco. Now, I really do trust Albert. He's a really good guy, and he does HDR. The question really, and this is a tough question, is whether he feels that the HDR alone is going to be sufficient, or whether he thinks you'll need IMRT as a boost across your pelvic girdle. And he worked with Mac Roach for quite a while, so he may say to you, look, HDR is good, but SBRT is easier, and we only have to do 2 or 3 sessions. So if he says to you SBRT, I would go with that. But I would trust what he tells you. The problem for you, of course, is it means you've got to travel. And if you're going to get IMRT, you might be able to get that IMRT part of it done up in Portland.
Yeah, that's what I'm thinking. Yeah, go ahead.
So, I think, John, my thinking is, how do we know the extent of the disease at this point in time, and what is the likelihood of micrometastasis? And that's really the call that a really good doctor like Chang can make.
Just to give you some info quickly, at OHSU they do SBRT.
Oh yeah, right.
Yes, yeah, no, I'm aware of that. But but the question is, are they doing high dose brachy there?
No, they don't do any brachy there, and the SBRT is not MR-Linac. It's a more conventional, earlier machine. But they do SBRT, and they do IMRT, and that's pretty much all they do that I can figure out in terms of radiation at OHSU for prostate cancer. There is a community hospital, Providence, that has an MR-Linac. The guy who runs that's one of the local people I'll be meeting with. But I'm especially interested, as you said, Rick, in what Dr. Chang has to say. My concern about combination therapy was really kicked off by a paper written by Peter Carroll and Daniel Spratt. I know you know who they are. Back in 2018, they did a paper. In fact, I jotted down the title of it. It's called Optimal Radical Therapy for Localized Prostate Cancer, Recreation of the Self-Fulfilling Prophecy with Combination Therapy. in that paper, they came out very against combination therapy, strongly against it. And the reason for that is, well, they had several arguments. They said the retrospective studies that support combination therapy can't be trusted. The randomized studies that suggest that it is superior merely shows that it's superior in terms of biochemical recurrence, but not distant metastasis. And in their paper, they said, really, distant metastasis has got to be the main endpoint, not biochemical recurrence. But their main problem was just the toxicity of it, that it's just so much higher than mono that they fear that combination therapy is over-treating a lot of guys, even though only a subset might actually benefit from it. And what they said in their paper was, now, as you may know, a lot of the studies on combination therapy involve LDR brachytherapy. In their paper, they alluded to the fact that, well, maybe if they did it with HDR brachytherapy, that might lower the toxicity a bit. And by total coincidence, this month, Juanita Crook, the Canadian researcher who does a lot of brachytherapy work, came out with a combination therapy randomized trial, or no, not randomized trial, just think it's just a group of guys who had HDR brachytherapy, had combination therapy with an HDR boost and had shockingly low toxicity. I mean, I don't even see toxicity rates that low with monotherapy. So I don't know, maybe with HDR rather than LDR, combination therapy might be a little safer. But I've also seen studies coming out of UCLA involving just brachy monotherapy that had rates pretty close to combination therapy, though I don't know why, since it doesn't address the pelvic girdle at all. Maybe somebody else has some thoughts on all that I just said.
Well, it depends too on how long those studies look back or are looking forward, because sometimes the consequences of local treatment don't manifest themselves for several years.
Right. No, most of these were like 8 years,
That's
8 years
good.
or so, 6
Well,
to 8.
I have to move on, but let's see what the experts advises you in this somewhat
Okay.
ambiguous situation. I personally would be a little bit concerned with the brachiolome, but tell us what the experts think. It'll be good for all of us to know.
Will do.
I'm going to go on to Michael Williams.
We kind of talked about what my concern was with somebody else a while ago, but I will bring it up. So over the since April of last year, I've had several PSAs done, not necessarily all my idea, but as I went and got second opinions, third opinions, everybody wanted to do one. And I was supposed to get one to be on routine in March, but I had to go to the GI doctor today and they wanted to do some blood work. And I said, well, can we just throw in a PSA since I'm getting stuck anyway? And I guess what bothers me, mine went up to 6.76 today. The previous highest had been 5.2. But if you look back to April, each and every one I've gotten has just kept trending up. Now, I don't have a high PSA density because I have a very large prostate. I don't know how much to read into that constant trend upward. It certainly concerns me.
Answer to interpreting an increase in PSA is in the next blood test, which leaves us in a situation of ambiguity and anxiety. Is it a little blip or is it a trend? What do you think? What's your doubling time maybe over the last, how long since you had half of this PSA level? How far back do we have to go till we get back to a 3.1 or whatever it is?
Probably 2019, but I have that here. because I stick
Well,
all of it in my
if
phone.
it's on the order of 2019, then that's an exquisitely long doubling time, and that's very nice. A PSA density that's low, and that's very nice. So you don't need to panic, but you do need to get another one, and that's how we're going to find out what this increase means.
Yeah, I guess.
There's some point at which your doctor will probably want another PET scan. I don't know if you've discussed when that will be.
Yeah, I've not ever had a PSMA PET scan. I suggested it, but they said with my 3+4 small percentage, I wasn't in a high enough risk group.
Next time you meet, say, well, what level of PSA would trigger you to scan me and see what it all means?
Fair enough. I should see them in, end of June or 1st of July. Mayo doesn't schedule an appointment out this far. You have to wait till 3 months before when they wanted to see me to schedule. So.
Oh, is that right? So you'll get another PSA before that visit?
Yeah, I'll for sure get another one after 90 days.
Right. That's what we want to see. Sandy, you have your hand raised?
Yes, I have a PSA of 3.1. I'm 3+4 on one core and 3 on two. However, PSMA has been scheduled this coming week by my doctor, my urologist. In addition, I have my first MRI, unfortunately, the same day. But he had, with a 3.1 in my condition, he went ahead and paid, said insurance will take care of it. Go ahead and get it done. So I'm curious to see what those results are, and I'll share it with you all next time I see you. I do have one other comment on that. Go ahead.
I'm not so sure insurance will take care of it. I mean, he may be able to get it through, but it's not commonplace to get a PSMA PET with a 3+4 because the likelihood with a 3+4, unless there is a large amount of cancer and it's somewhere and it's located somewhere close to the edge or close to the bladder neck or something like that, you're not going to see anything. The PSMA test was really designed for people with 4+3 and 4+4 and higher to try and determine if the disease had spread outside the gland.
Right.
Now,
yeah.
I know that people hear it and they want every test that's available. We don't push PSMA PETs for people with lesser disease. Occasionally, it's right. I guess it's fine, but don't be surprised if they come back and they say, sorry, we won't approve it.
Yeah, I better call Medicare up front. A related question while I have your attention. Someone on this forum, I believe last week, mentioned when I get the MRI, I should request glucogan to be put in the IV. Is that something the lab guy would determine and keeps apparently the vibration of the colon from happening so you get a better scan? I don't know who said that on here, but anyone know anything about that?
I'm not sure it was on here. You might have picked it up off a written forum, but it's not anything I've heard of. Has anybody else heard of this, Dr. John?
No.
Okay.
No. I don't think it was here that you heard of.
Yeah.
But it might have been, but it's not. It could have been.
I heard that too. That somebody did say that.
Yeah, you remember it was a week or two ago.
Okay.
4 weeks. So. Anyway, my question is, would it hurt to ask the tech to put that in the IV? Is that something he determines, or my doctor, or what?
It would have to be the doctor. Glucagon is not a toxic drug or anything. It won't hurt you. But the question is, will it help? And I guess none of us are really knowledgeable about that.
Okay, I won't worry about it then. They're going to do the dye anyway, so whatever. Okay.
Yeah.
Thank you very much.
If you find out, Sandy, whether that is important to do for an MRI. Would you send me an email and inform me about it? I
Certainly
would
will.
love to know.
Certainly will. Okay, thanks, guys.
Is that what you wanted to bring up, Sandy?
Yes, that was my issue. Has anyone had this done on an MRI, and was it somehow better to view the result, or what does it mean? I'm not going to worry about it. It sounds like so. All right, very good. And as for the PSMA, Rick, I better call the insurance, make sure, because it's
I
probably
would, because
pretty
better to be safe than sorry.
betcha.
Is this the doctor at Stanford who's ordered
No,
it?
this is my original urologist that we
Okay.
recommended. I looked for another one. Remember?
You know, then if it were me, Sandy, I wouldn't even be dealing with him. I mean,
Yeah,
I don't know. We've given you plenty of information on the fact that we don't think he's that reliable. And I would just shut up shop. It's not that urgent, and get your ass over to Stanford.
Oh, I've got an appointment, Stanford, with the recommended.
Okay, so I wouldn't do any more testing with this guy.
Yeah. Okay.
He's not reliable. I mean, then when you'll come back and you'll say, "Oh my gosh, he said he could do this and that. And he was going to get it paid for, and he didn't get it paid for. Now what do I do?"
Yeah.
Well, we're telling you right now, can him.
Yeah.
I
It's
mean,
probably not too late.
Greg Burns told you, can him.
Yeah.
We
Probably
told
not
you,
too late to
can
cancel.
him.
But the MRI would be helpful, would it not? I might as well have that.
Do it all at Stanford.
Yeah.
Because they're going to tell you, the next thing they're going to tell you, oh, well, we don't trust the MRI that they did.
Yeah. It's a 1.5 too that's scheduled.
So, but we've told you this, Sandy.
Yeah. I got
Now,
you.
why do I get upset? Because I get upset because we give you the advice and we told you don't use a 1.5T, go for a 3T. And we've said to you don't use this guy, and he's doing a PSMA PET. Why? Because he can bill you for it and make some money.
Could be. All right. Well, I'll listen, Rick. I'll listen.
Please, you don't have to take our advice, but neither do you have to come back and go over stuff that we've talked about before, because we can't afford that.
Sure. I just figured,
this
why not
guy
do it? Why
is
not do
not
it?
a great doc in our view, and you heard it not just from us. You heard it from another guy who took his business somewhere else, and he's very happy there.
Gotcha. Okay.
Okay, message received.
Message received. Thanks, guys.
Michael, what do you got? Got a comment or a question?
I was just going to second that for Sandy. I'm a 3+4 as well, and was told it was going to be covered by Medicare, and went in, and I ended up having to pay for it. So,
what did you say? What was the?
I had a PSMA PET scan, and I was told it was going to be covered. I'm a 3+4, and it was not.
It was not.
No.
Was it diagnosed after the fact? I mean, was it rejected after you actually had it?
Yeah, I got a surprise bill with it. So.
Oh boy.
Thank you.
Yep.
Okay, prior approvals, guys.
Yep.
I have gotten through the list. Is there anybody that would like to say or ask or bring up anything before we wrap up?
I'd like to ask you a question, David. If David, what do you mind if I called you, David S?
Sure. Who am I talking with?
This is me, Dave, up here.
Yeah, sure. By all means.
We have a similar situation. Give me your number, if you will.
Okay. Well, let me put it in the chat box. That's not public, right? The chat box.
Yes, it is public unless you
No. We sanitize it for. First of all, if you send it to him directly, and not to everyone, it won't be public. If you put contact details in the chat, we sanitize them before we publish them.
You don't have to. I'll give you my number.
Okay.
303.
John, I think Michael asked for some time this evening.
Which Michael Denver, Michael?
303.
Michael Tennessee.
Michael Tennessee. I think he asked for some time.
Didn't I just go to you?
Yeah, I wanted to point that out about Sandy, but the last thing, or the main thing I have for myself was.
Oh, very good. Go ahead. Yeah.
I'm going through the second opinion process, and I've got as well as some different doctors I'm talking to, including Sanda. But I guess from second opinions, do you guys? You mentioned the biopsy second opinions. Do you recommend doing the same thing for the MRIs and the PETs?
Well, that's a good question, and we certainly debated this very hot and heavy for a couple of years after PSMA PETs first came out, because we felt that there was probably a learning curve amongst the people reading them, and we did. At this point, and I would like Rick's input on this, I think that um, uh, the reading of MRIs and the reading of PSMA PET scans are now reliable. The word reliable means if two different examiners come up with the same result, then that's reliable. Are reliable enough to not have to go off and get another reading. But let me hear from Rick on this.
Real hard. I don't have a set view. I think if, to begin with, when PSMA PETs were first initiated, I don't think there was enough experience, and a couple of the people tried to initiate some AI, but it was expensive and it didn't really pick up. You can get a free review of all of your tests, including PSMA PETs and MRIs from the NIH. There's a website there. I just found it.
I've actually got it. I just remember you saying you weren't a fan of them, so I didn't know if, if it was worth the hassle.
I mean, I don't have enough experience to tell you, and I think in one of the groups just recently we put the name of the radiation oncologist who does second opinions there. We used to have a guy called Wes Phelan up in the UW, University of Washington, who would give us second opinions, but I think he got into trouble for doing it too often, and now asks for a donation to the UW Foundation or something. I don't know. I really don't. I don't know.
I will say this about MRI scans, though, even though there's many, many years experience and a lot of reliability, PIRAD scores themselves are not as highly reliable as reading anatomic results off MRI scans. You can get different PIRAD scores from different radiologists, so I would make that one little warning.
Okay. Well, thank you.
You're welcome.
You know, my question, and we'll go to Eric, but my question is, have you reached out to Dr. Sanda?
That's on my list today. I've got Sanda to reach out to, as well as send the information to Epstein and Zal. And yeah, that's what I wanted to come to this meeting for. I went to the active surveillance meeting and now this one, and I figured after this one, I'll actually take action. I guess that is one last question. Do I have time to do this type of stuff, or do I need to?
Most likely, yes. I mean, you know, even if you're a 3+4, right?
Correct.
So, as a 3+4, you probably have a bunch of time. I mean, I was a stage 3, 4+4, and I had 4 or 5. I was given 4 or 5 months.
Okay.
So prostate cancer usually doesn't grow that quickly, and I think you have plenty of time. I mean, you shouldn't feel pressured by time. Did you? How old are you, Michael?
46.
You mentioned Medicare.
Yeah.
Are you on Medicare?
I was actually, I was on Medicare previously for a brain situation.
Okay.
Completely unrelated.
Oh
Um,
yeah, no. I get it, but I thought I seem to remember you were 46 in your 40s, and I'm thinking, I wonder how come
yeah,
he got that situation. But now it makes sense. So forgive me for asking.
no, it's that's fair. I was on disability for about 8 years until they found out what was going on with my head.
Okay,
Since I'm off of that, I'm still on Medicare, but
yeah.
the SSDI has gone away, um, and now this popped up. So here we go again, I guess, with doctors. So we'll see.
Um,
Well,
yeah. Well, something going on in up top is actually Dr. John's area of expertise.
It was a dural fistula, if you're familiar with that. They said they usually catch them post mortem, so I felt very, very fortunate and blessed
Yeah,
that they actually figured out. They ended up building a bunch of aneurysms around the base of my skull. I got really lucky. So, um,
that's really lucky. Those are catastrophic events when they happen.
so
Yeah.
hope we get lucky on this one again too. Just try and get some
Yep, hope
information.
so.
I have a point for Michael. Not to scare you, but I was in your situation. 6 months ago, I went from 3.3 to 3.4, and I waited. I waited because I was looking at all these modalities so I have the least side effects for my girlfriend. It turns out that it went to 4.4 in 6 months, and now I'm kind of screwed because I can't go back to those other more benign modalities.
Right.
Well, but David, here's the issue. Those biopsies were never you never got a second opinion on them,
True.
and so you may have gone, but you may not have gone. And this is why we really it's one of the few things we sort of recommend if there's any doubt at all is get a second opinion on those on those biopsy slides.
Yeah. Okay.
So we hope that a second opinion was needed. Maybe it isn't needed, but maybe something else will turn up. But now that it's gone and proceeded to crib reform, even more so. No, wait a minute. It wasn't you. It was David S. that had crib reform, right? You don't have crib reform, right, David P?
I have cribiform, yes.
Oh, you do.
Yeah.
So, again, crib reform's interesting because again, it's a morphology that is relatively recent. It wasn't reported 10 or 15 years ago. And so it all depends who's looking at it and who sees it. And there are degrees. And if it's larger than a certain amount or smaller than a certain amount. So
Yeah.
it's really, really tricky. And for me, if Dr. Zhu or Dr. Epstein or Johns Hopkins lab says it's cribiform, I say fine. If it's anybody else, or maybe the guy, who was the guy that we heard the lecture from? Where was he from? I can't remember.
Frendel.
You know who I'm talking about, John, who did the lecture on urology on Euro Today.
Don't remember who it was.
Yeah, there's a very good lecture. I'll see if I can put
It was Jesse McKinney. Jesse McKinney.
Yeah, Jesse
Oh,
McKinney.
yes, Jesse, yes.
Jesse McKinney. So if fine. Where is he, David S? I can't remember.
Cleveland Clinic.
Cleveland Clinic. Thank you. So yeah, do you have the do you have the link for David P to look at handy?
Of the Jesse McKinney interview, yes, I can dig that up.
Thank you. So yeah, I mean, I would look at that, but there's a lot of subjectivity in reading these MRI, in reading these pathology slides.
Cribiform, it's funny that this is an offset. I mean, it's not that difficult. It's not that subtle, really, but I don't know. Eric, you have your hand up.
Oh, hey, I just wanted to piggyback on all these scans, and my opinion is when you have humans reading imagery, that it's always best to have a second opinion. There's always room for error when you have humans involved. So if you're trying to make a treatment decision, get a second opinion.
I saw a study one time. It wasn't about pathology; it was about clinical care. But they they scored how good of a job a doctor was on their own. They then uh, gave him access to an AI and scored how good he was with the AI. And then they scored the AI alone. Well, it turned out that the more the human was involved, the less accurate the care was. Uh, so the doctor actually worsened the performance of the AI in that particular case. So yes, you're very right.
Yeah, I mean, you get tired one day, you're rushing to go home, whatever, all
Yeah.
those things play a role.
Surgeons actually have more complications the day after a vacation. You'd think they'd be better rested, but it, they vary according to the day of the week. It's just amazing.
Especially with Pyrite score too.
Yeah, yeah. Okay, folks. I guess we're done. Let's leave that up on the chat long enough for people that are interested to get those links. But
Thank you.
otherwise,
Yeah, thank you, David, for posting that McKinney link. And I just put in the NIH Second Opinion Clinic for prostate cancer link.
good.
And then there's a particular doctor that I can also put his link in there.
Chote, Dr.
You
Chote?
know, what's that,
Was it
Eric?
Dr. Chote?
Yes, yeah. And I think I have that. I think I have that more readily.
I think I have it.
Choik. Here you go. So I'll put this in too. Thank you, Michael. I think what Michael from Tennessee might be thinking of is that our concern with the NIH is really in how they treat more advanced cancer. We don't. We have no bad opinion on their diagnosis or anything like that, but we have had with people who have had well advanced prostate cancer. I personally am not convinced that they are the best place to be treated. And one of the reasons for that is they're not collaborative. They don't want to talk to anybody outside of the NIH. If anything, they're very protective. And we've seen the results of that, especially with respect to people who are employees at the NIH. And it's bothersome. So I don't want to say don't go to the NIH, but I would say that if you have an advanced prostate cancer situation, the NIH may not be the best place to get treated, based on our anecdotal experience of a couple of different people that we've seen there.
Well, good night, everybody. Thank you for coming. Dr. Mark will be back next time.
Sweet. John, we've had somebody in the bottom corner that says MICYABO. Do we know who that is? Are you there? Your mic is on. We'd like to say hello to you. Do you see that, John?
I do. He came in after the
Yes.
time, so I thought I would just make sure nobody wanted to volunteer anything.
Yes,
But I don't
that's
know.
okay. But you're very welcome to speak. And next week we've got high risk. Next week we've got high risk tomorrow. We've got active surveillance on Wednesday. So we have all three groups this week. Oh, and we have under 60s for stage 3 and stage 4 on Thursday, which Bill Franklin will be moderating on my behalf. So,
all right. Good night, folks.
Thank you all.
Good night,
Everybody got
everybody.
your links? Okay.
Thanks so
Thank you,
much.
Ron.
Good night. David P.
Yeah.
David P, did you send me your? Can you send me your email address? Because I want to try and check and see if you've if I've got anything from you.
Yeah, I'll do it.
And David, were
Yeah.
did you still want to get in touch with me?
Sure.
What's the best way you can give me your phone number?
I'll just tell you right now, 303.
Whoa. Just put it in the chat, please.
Oh, okay. I'll
Okay,
do it.
well,
Thanks.
we've just stopped the recording, I hope.
Okay, if we stop the recording, then it's okay.